to be there. Okay.
Terrific.
Okay, good. All right, let's see now. I got to get over and see who's on from our panel. It's an interesting day. There are about, I would say, 7 people that already contacted me that said they're going to be in the dentist office, that they may be listening in, or in the doctor's office. So it's like, apparently this is a big dentist doctor's day. So I did mine yesterday. I did the ophthalmologist, and we had a little procedure and everything. And an hour later, I got on an airplane and came out here to Las Vegas. So okay, very good, John. Hey, John, I don't want to put you on the spot, but can you talk about a couple things, such as, Alaska pox, if that's something we need to know about, and then of course measles is now showing up everywhere, and maybe give us a little things about how we should relate to that, particularly in EMS. Is there anything we need to get out to our people, and and then remind us about how it usually presents, for adults, which is different than in children, etc. So, okay. And hopefully we won't see it in adults, but who knows, right? With the way things are going nowadays. All right, is it okay for you,
Yeah,
John? What's your
yeah,
schedule?
I'm okay for the whole duration, Paul.
Oh, perfect then. Okay, good. Then I can play that by ear, according to what I need to get done. All righty. Well, let's see then. Let's go ahead and then get started. I'm trying to see if Ben Weston's on yet. Ben, are you on yet? Not yet. Well, he's going to do it. And then Corey was supposed to give a presentation today, but he had there's a fellowship interview day, so he's going to miss out, unfortunately. So are several other people. Use everyone when you write a comment. Okay, good. Thanks, Peter, for putting that in for me. I appreciate it. Okay. Okay. Oh, yeah. So Sandy was yeah, in my situation, it was actually a bizarre little thing. I thought I had a retinal detachment because I was seeing the little flash and floaters. And it turned out that they're not sure how it might have happened. It may have been traumatic because I did do something interesting about a week ago, but I had a little tear apparently, way over laterally, and they just lasered it down right on the spot. It was pretty cool, actually. Interesting procedure to go through if you haven't done that. So anyways, it just old age creeping up with me, right? So all right.
Yeah, you're getting
Yeah.
really old. Really. You're getting older faster than any of us are getting older.
That's right. I'm working on it. So all righty. Well, listen, let's get on with the meeting, and let's see if we haven't got if Ben's not on yet. I'm trying to think who else I had. Let me see if the schedule. I couldn't print out my agenda, so I'm gonna have to jump over there and look at it here real quick. So we're gonna have oh yeah. Delivery. Okay, John. Oh yeah, Joel's supposed to give a talk too. So our speakers are not on yet. So we could just go on and just get some general comments. And Sandy, why don't you go ahead and give us a report, if you don't mind, then from ACEP while we got you on, you're there, okay? And while I'm buying time for everybody else. All right.
No problem. Well, ACEP's sort of news is EMS Week, EMS Week, EMS Week. It is again happening this year. It is the 50th anniversary of EMS Week, so that gets a big deal. We're very pleased that George Solomon is really stepping up and putting together things. We got a little bit of a late start with the transition to him for the team with the team. Pat Elms, who some of you know from before, he's helping out. He's being brought in as a part-time, or as a full-time rather, but short-term contractor. And so we're expecting this to be everything it should be. And if you have any questions, take them to George, because I probably don't know the answer to them. And then the other thing is once EMS week is over, and put to bed and everybody is honored in the correct way, we'll be going back to some of the work plans that we have to create a disaster readiness checklist, and work on creating disaster as the next subspecialty within emergency medicine. And actually it'll be open to all specialties. So that's
Okay.
pretty much.
All right. Anybody have any questions for her? And then remind us again when the event called ACEP, assembly is taking place.
Yes, so we've got 3 meetings coming up. We have ACEP Accelerate which is next month, early next month, which is really 4 meetings at the same time. There's a PEDS assembly, which is the one that I think is the coolest, but there's also teaching fellowship and the ED Directors Academy and reimbursement and coding. Almost forgot it. This is probably going to be our plan going forward, is to take these smaller meetings and bring them all together. We can get a better venue. This venue, by the way, is the Lowe's absolutely totally brand new hotel, opened 2 days ago, which is sort of really cool down in Arlington. And if you happen to be going, you might want to get tickets because there's going to be some really big concerts in the area. Stevie Nicks is going to be there. I know my husband's drooling over that. And some other people. Some of you are too young to even know who Stevie Nicks is. But anyhow, she's really cool. The second meeting is the Leadership and Advocacy meeting, which will be in April this year in Washington, D.C. And the day after that will be EMS on the Hill with ACEP in conjunction with NAEMT. And so we're very excited about that. And then we're going to, our meeting will be in Las Vegas, and it's like September 29th through October 3rd or something. It's
Yes,
early this year.
that's exactly right. Yeah.
Did I mention it was in Vegas? And did I mention that Vegas has the best food in the world?
Yeah.
It's absolutely amazing. Mick, you got to come over and have some. I'll treat you to a drink, and maybe we'll go out to dinner because it's absolutely fabulous.
Well, I've been exploring all the different Vegas places over the last I've been exploring all the various places over the last 2 months, and I found places I didn't even know existed before. And you're right, there's some really great stuff here. So,
Uh, if,
and
if you want somebody to tell you, Chris Kang, past president of ASEP, knows
yes,
every place, showed me every secret door for every speakeasy that doesn't have a sign on it. Oh my God, the man's incredible.
I know what you're talking about too. That's just really good. Yeah, Chris is actually, not only is he got good taste, but he really is very resourceful that way, and he's got good taste, and that's even better, right? So I've had the experience with him from Barcelona to, wherever. All right.
Yeah.
Well, thank you very. Hey, I haven't got a response from your president yet. Just want you to know, but I did email her. So if you want to follow up on that for me, okay?
Take
So,
care of that.
all right, good. And then, and you're planning on coming as well, I assume.
Yes, I
In Fort Lauderdale. Yep.
Yep.
Okay, good. All right, good, Sandy. Thank you. All righty. So let's go ahead and start in. Anybody have any particular burning questions that have to get off pretty soon? Anybody that has to get off soon before I start getting into some of our discussion, so to speak?
I actually have a question for Sandy, actually, Paul.
Okay, go ahead, David. Yeah.
So, Sandy, I was wondering, are governmental affairs or advocacy folks at ACEP working with the DEA at all on the DEA rules for us in EMS? Because, I mean, a lot of us are kind of being held out to dry here on the DEA regulation. Manifold did a great job at getting it across the finish line through Congress, but we still have no rules.
Yeah. Welcome to the club.
Before you go, Sandy, before you go further, Dave, can you be more specific about what the one or two issues are, just so that?
Yeah. So, previous to, well, right now, an EMS provider is a mid-level provider. So when San Antonio Fire buys a pallet of morphine or fentanyl, it gets flagged and says, "Hey, what's the deal? Why is a PA ordering a pallet of morphine?" Right? And so we actually had to become a distributor, like McKesson or Boundary or whatever. And a lot of our docs have EMS agencies with their private DEA number. That's a no-no, right? There's problems with enforcement. For example, the DEA agent in Houston is different than the DEA agent in Dallas.
Oh yeah.
So
right.
the rules are interpreted differently. So we don't have any rules with the enabling legislation, so that we know how to act, when to act, and what things to sign, what things not to sign.
And
It's
David, let
really
me
a
interrupt
problem.
you. David, let me interrupt you. You said we have to be a distributor like McKesson or whatever. When the word "we" is that medical
The
director,
fire department,
fire
the
department,
fire department
fire
had to
department.
become a distributor.
Yeah.
Right.
Okay.
So
Yeah.
that means a lot of cost, inspections. Took us months and months and months to do that. And I don't think it's fair that we have this law that's been on the book for years And yet we still have no guidance from our lovely legal friends at the DA that have guns and badges.
And David, in the past, we've had problems where each fire station, wherever the drug was stored,
Had to have
be registered as a separate site and then needed a different DEA number. Is that still an issue?
It is, it's just not being enforced per se, depending on the inspector. And it's even worse. If you move medication, say from supply to fire station 22, you have to do a DA 222 paper form and document that. And the form has to be signed on site. It's in triplicate. It's all kinds of drama, right? And so they're not enforcing those rules right now, but it still makes it very difficult. The intent of the law was to go back the way we used to do, where we have essential stores, we have supervisors that can distribute the medications on the units, we have our own internal documentation, there's one license for the entire organization. If the organization goes across state lines, you have to have two, but that's different. But I mean, the thing is to make it easier on our EMS partners and make it less liability that we're going to get busted by the DA.
John Kramer, you've been dealing with this for a long time. You want to tell us a little bit about your perspective on it?
I don't want to interrupt Sandy if she has any response, and then I'll provide my editorial comments.
Go
Okay.
editorial, go.
Yeah, editorial comments, folks. This is something that you're going to have to make your elected congressional representatives aware of, and they have to put pressure on the DEA. This is not something that the DEA will do on its own. It's not a high enough priority for them. They're not particularly interested. They have drafted the rules, but haven't done anything with it. And, you know, David's right that it is consistent. It is inconsistent DEA inspector to DEA inspector. So you really need to make your congressional representatives aware of it and have them put pressure on DEA, because they have a timeline mandate to implement those rules, and they're just ignoring it.
Well, the other thing is that, so Mick was asking the question, and so Mick, it's not only from state to state, but even within the same state, we're seeing, depending on what region you're in, you'll have different people have given different opinions, and they've been really quite different, going on. So, but the other thing is that sometimes an individual, congressional person is, could be sensitive or insensitive about this, but I think that's why it is great to have someone like Sandy even giving us some leadership and advocacy and helping us with maybe knowing what to say or how to approach those congressional people, because we don't normally do that. And then of course we probably have to coordinate that often through our fire departments or leadership people, etc. So Joseph Zalkin, why don't you go ahead and make your comment?
Yeah, just briefly. NMSP went on the Hill in June and met with the writer of the original congressional act, which passed 4 years ago. And there was a joint bipartisan letter sent to DEA saying to get your act together. It's been 4 years. It was introduced in the Federal Registry. There was a comment period, and there are no enforcement documents. The enforcement documents from the feds will supersede anything the state has done and have universal guidance. It includes a lot of the adjustments that Dr. Miramontes was talking about, multiple sites having to be registered. That goes away. There's a lot of improvements. But so far, the DEA has not taken action. And that's with a recent bipartisan letter from Congress saying to get your act together.
Yeah.
Yeah.
And then someone,
Right.
before I go to Sandy, John Jew has no problems in his area, right? But we have significant ones in various other states that we're dealing with. Sandy, go ahead.
Yeah, I was going to say, in our dealings with the FDA regarding some of the opioid issues, et cetera, the feeling of our DC staff is they are a totally dysfunctional group of people who sort of do their own thing in their own way. So I agree with John that the best thing to do here is to talk to your elected representatives. There will be there's 3 options for that. One is write your congressman. Number 2, if you want to come to the leadership and advocacy meeting, there will be other issues that we'll be discussing on the Hill, but Tuesday morning of that meeting, I'm sorry, I don't have the exact date, but Tuesday morning of that meeting, will be a training session on how to talk to your legislators. And it's really interesting. They just have this sort of like cookbook, you do this, you do that, you do this, and who you'll be, and there will be meetings set up for you with all of your representatives in your area, as well as your two senators. Often it's with staff, but as we've come to know, staff is probably in some cases better. And then the next day after that will be EMS on the Hill. So NAEMT will be handling that. And again, if you could stay in Washington, you could go back and see the same people again, but with this. So I think, this is where you just have to do the work. I will get our DC office on it and make sure that they're aware, but it's going to be individual elected officials.
So one thing, could you give us like a model letter? Can someone develop something like that and maybe send it off to someone like Jim Augustine here, and then in turn we could distribute it to our people here as well? That might be is that feasible?
I'll certainly try.
Okay, thank you.
Mhm.
All right, so let's move on then. We got a couple of our other people. Anybody else have anything, or that they have to get off soon? So I could plug them in now before we get going with our topics for the day. And Tom Collins, good to see you. Anything new to report out of Cleveland? Because you've been busy and missing Fridays, but we're glad you're here.
We're good with our safety divisions here, keeping with our NFL banter. Even though DeMar Hamlin came back from the dead, Joe Flacco got the Comeback Player of the Year award for the NFL last year. So it's much more impressive to bring the Browns to the playoffs than to come back from the dead, is the take-home message.
Yeah. And speaking of which, just another awfulness. I was going to hopefully have a couple of they weren't sure if they can make it, our Kansas City folks on, with what happened there at that, joyous event, etc. And the same thing happened out in Denver as well, with the NBA last year. There's always something going on. So that was kind of a shame. And it was interesting, Peter, that happened on Wednesday, Valentine's Day as well, right? And that was our 6-year anniversary of our event that happened in Parkland. So just so much for for Valentine's Day being one of love and kindness. So really is terrible. So it's good.
Yeah, there was also one in school, I believe, in Georgia, if I'm not mistaken. So there was 2 shootings.
Yeah.
But
that's why in the notes I put something like by that time we had 48. Well, they consider something a multiple casualty incident related to active shooters if it's 5 or more, I think, is some kind of the official. And there's more that involved 5 or 6 or whatever. But they had tallied 48 within the first month and a half, which is just kind of awful. That's all I can say. So. All right. And hey, Peter, any reflections from that day before I move on to Ben?
a few people called me and texted me. I think that for me, as the years go by, it becomes a little bit easier. But it's still a little upsetting to me that the building is still up.
Yeah,
the building was supposed to be torn down. Every year, as you know, Paul, because you've been there, there's a kind of a breakfast, a first responder breakfast, if you will.
Right.
But you go there, and none of the kids who were there, who were at the breakfast, were even, they were all in middle school back then. So, I think some things that are being done are probably not as healthy as they should be, but it's gotten better for me, a little bit better every year.
Yeah.
Except when these events happen on the anniversary. But back to you, Paul. Thanks. You've been very helpful for me. Thank you.
That session we had a couple years ago really was an eye opener, not only for our audience, but so also the people on the stage that were giving the comments. So and that's part of it, is working through that. It's still pretty awful. I did talk to at some length or been communicating is a better way of putting it, on and off here, with our Eagle in Kansas City, and it's been a lot of disturbing things. And so in any event, she got a lot of feedback from you guys or contact, and that was well appreciated. And so thank you so much then for reaching out to Erica And that's made a difference. And that we heard that in the past, from people like Corey. And we'll see, maybe next week we could talk about that in a little detail. I want to skip over that for today, though. Well, in any event, let's move on then to Ben Weston. Ben, you're going to be putting out something to EMS World, I believe, pretty soon. And so what we want to do was have you go ahead and present it a little bit and see if you get any feedback or anything we've left out or anything we need to put in as a caveat for your presentation that you're doing. Is that okay?
Sounds good.
Okay, good. Well, where are you today? You're driving in your car?
I'm moving around a little bit, but parked
Yeah.
for now.
So just as a quick introduction for those who may not know it, but I don't know why you wouldn't, but in the case, Ben is not only our medical director there in Milwaukee, but also, the health advisor for the county. And so as a result, he kind of got into looking out for the, let's say the public health of various people. And there's a lot of, a multitude of various ethnic groups within Milwaukee. And he became really hypersensitive, I would say. The hyper is a wrong word, but just a very, very sensitive to, to the needs of people and maybe potential disparities. But it's a little bit more complicated than just looking at numbers. And sometimes it has various implications. And he's drilled down on this very nicely with his, dashboards and so on. And so I'll let you take it away. I just wanted to present a little bit of the background and how cool it is that you, and by the way, this has become a hot topic amongst people, like including the National Fire Academy, the International Association of Fire Chiefs. Oh, this is a big hot topic of the issues of disparities in population medicine. And Ben has been our expert on there, and they've been all very glad to have him as a resource. So it's been fantastic. So thank you very much, Ben. Why don't you go ahead and take it away?
Yeah, thanks, Paul. So we've been doing these quarterly articles for EMS World, and this quarter we decided to kind of focus on some recent disparity research. And it was looking at pre-hospital emergency care, the journal, and they did a special section back in, I think it was maybe late fall, early winter.
Yeah.
And they called it the focus on disparities. And so we kind of talked about the different articles that came out, which are kind of the newest articles, the newest research right now, focusing on disparities. So the probably largest article was by Andra Farkas and others. And that was just a scoping review of all the literature that's out there in the pre-hospital space on disparities. There's not a lot out there, but they did a nice review of what is out there. Most of it revolves around the typical stuff you'd imagine, kind of access to EMS, pre-arrival on scene and treatment interactions, and then disposition. Most disparities research is around cardiac arrest, which isn't terribly surprising, followed by ACS and stroke. And so it's just a really nice, if there's one article to read, I think that's the one, because it really nicely summarizes kind of the disparities research that is out there right now. But also the gaps in disparity research is out there. There's not much multi-system research at all. There's not much research from systems that have comprehensive reporting on race ethnicity. Most have, other or not recorded field, which makes the data just kind of messy and biased. But there were a few other articles to highlight and jump in with questions anytime, just interrupt me. So one was Graham and colleagues. They used the ROC data. So this was multi-system data to look at sex disparities in care, specifically around cardiac arrest. This has been done before, but this was nice because it was a multi-system data set. Not comprehensive race ethnicity information, but still multi-system. And they saw some of the same things that other studies have seen. So men were more likely to receive certain interventions, defibrillation, epinephrine, bystander CPR as well. And because of that, they found that survival to hospital discharge was higher for men. Now, this is different from some past research, which Paul was involved in as well. They did say there's some things that may have kind of skewed this. So there were differences in age between the men and the women in the group, and so that certainly may impact it. Men were more likely to have shockable VF, obviously more survivable rhythm, so that may impact it. And then that bystander CPR ratio certainly may impact it. But nonetheless, disparities kind of across the board from a sex perspective between men and women around cardiac arrest, which really does repeat what's been done in the past. Yeah, Paul.
Yeah, so I'll make the comment. So I'll drill what Ben has really nicely done here is drill down on that. So if you just, and this is important for us to always stratify things accordingly. So if you take cardiac arrest, overall, you'll see men have better outcomes and men got shocked more often, whether. But then when you drill down on it, it turns out that men have ventricular fibrillation, more often. The women are older, etc., and so therefore they won't get shocked, and they are older. And also, let's say the men get the CPR more often because their mate is still alive to do it. And so if you drill down on that further, you'll see that the reason part is because a lot of times women are older and they're living alone, etc., under those periods of time. So there's all those kinds of things to drill down on. Nonetheless, there are data, particularly in terms of STEMI care, where there definitely is, I think, a lack of aggressiveness sometimes with respect to women. So the point I'm getting at, though, is you got to drill down on it and not just look at the surface value of things sometimes. And so the better we collect the data and the better we look at it, the important. That's just one quick comment, and you did that really nicely in your article, then, Ben, as well.
Yeah, thank you. And I saw a comment from Joel about the links. Unfortunately, I'm on my phone working off pen and paper scribbles here. So, but I'm happy to send it out. Otherwise, if you want it sooner than I can send it out, it's that section from, I think it's not the most recent, but second most recent PEC. And it's the articles out of that section. But I'm happy to send a link out.
And tell them again who the first author is.
So the first one I talked about, the scoping review, was Farkas, FARCAS.
Yes.
The second one was Graham, GRAMM. And then the third one is Grubic, GRUBIC. And this one looked at this was a global view on high income versus low income countries and what type of bystander interventions they have and bystander intervention programs. And perhaps not surprisingly, low income countries have less bystander intervention programs, mostly around cardiac arrest interventions, but kind of across the board. And then branching out. Oh, go ahead, Paul.
By the way, we speak about being in other countries where it's clearly overall they don't have it, but if you drill down in our own country, particularly if there are language barriers and so on, you definitely see a lot less bystander CPR, a lot less training out there in the community. So those are really existing disparities that we're seeing within our own country that way too.
Yeah, absolutely. Absolutely. And actually on that note, so the next study, which was related, was Hubinger, HUEBINGER. And they focused just on Texas. And they looked at how often first responder CPR is being performed based on racial and ethnic differences in different geographic areas, as well as just overall socioeconomic status. And they found that when African-American populations were present, when incomes were lower, unemployment was higher, there across the board, there were lower frequencies of first responder and of bystander CPR. So not just racial and ethnic disparities, but whether it's income, unemployment, overall socioeconomic status, significant disparities going on there as well. So I think that one to me is kind of a reminder that I feel like sometimes the disparity research seems like kind of a niche issue for a small part of your population. But if you add up the women, the populations of color, unemployed, unsheltered, low income populations in your community, I mean, you're probably talking about 90% of your patients, when you add all those up, if not more. And so these are not really niche issues. And when you start looking at your QI data and break it out, I think you start to realize that.
Yeah, and interesting thing, Ben, I think you brought out, or maybe we discussed, I can't remember, but it could even also apply to age. So there is discrimination that goes on to some degree. Some of this is basically socioeconomic, right, and educational stuff. But there also is some bias. For example, one of the things that we found years ago is that the elderly actually had a higher rate of resuscitation, and yet they were less apt to get out of the hospital alive. So we don't know if they were treated as aggressively, or is that just the natural state of things, and that needs to be investigated, right? So
yeah. The next one was interesting because it looked at sheltered versus unsheltered, which hasn't been, or homeless versus housed, which hasn't been as much of a focus of disparities research. So this was Curtis, was the author, and this one focused on chest pain overall. and unsheltered populations were less likely to get aspirin, nitro, any type of analgesia, and less likely to have IV access obtained. So they were also more likely to have their chest pain described as non-cardiac as opposed to cardiac. So this was a relatively unique one in that it looked at that unsheltered population and had the data to record that. I don't think most systems are recording, sheltered versus unsheltered or stable versus unstable housing in their patient care records. So that one was kind of unique and interesting.
That was out of San Francisco, if I remember, right?
I believe that's right. Yeah.
Yeah, that's good. So if I and we're not going to leave the subject quite yet, but we're a little bit of a tangent, is that one of the purposes for doing this is seeing how we can adjust ourselves or what we do or educate our folks to pay attention to these kinds of things better. And Meg, you've done that in New Orleans, Meg Marino, right? In terms of looking at diversity of the staff or sensitivities to the various cultures as well that you're dealing with in your arena. You want to make a quick comment about that?
Yes, so thanks so much, Paul. We serve a very diverse city, and we've been focused on the last several years and figuring out what we can do to make sure that we're providing culturally competent care to all of our patients, and also to making sure that our staff represents the community that we serve.
Yeah, and so what specifically have you done to do that, or what are some of the strategies you've used?
So one of the strategies that we've used is we've created pins that providers can choose to wear on their shirts. So Black Lives Matter pins, and Pride pins that serve as a visual cue to show that we support members of the community from different backgrounds. That's been shown to improve the patient satisfaction of people from diverse backgrounds. They feel more comfortable if there is some visual cue showing that that person is an ally. We've also been doing some diversity interview questions in the recruitment process. One, to show that this is an important piece of our kind of agency culture from the get-go, but also to kind of see how people would answer or handle difficult situations with people from different cultural backgrounds. And so it's been enlightening to see people's answers, but I think also it's shown people have said that they really appreciate our focus on that.
Yeah, and that's what's good. In early training, early up front, particularly with the new people coming in and making it part of their orientation is a critical part of that. Just the setup, and even warn them that they're going to have the older folks sometimes not, let's say, as compliant or that kind of thing, and so that they have to be the new generation that makes things better. So that would be, yeah, I think it's been really important. So thank you so much for your work that you did there.
Well, thank you.
Yeah, anybody else have any other comments or questions for Ben before we move on? We just want to make sure we're stimulating this, and it'll be a part of our discussion that we'll have in Fort Lauderdale when we get down there. Okay, so all right, with no other questions, pop it up, Ben, as usual. Thanks a lot. Thanks for you guys doing that work of getting those articles out every quarter.
Oh, thank you.
It's really kind of cool for us to have that and have a leader like you doing that. Okay, so
I appreciate that. It's been fun.
All right, good. Let's see now. Okay, so we're getting ready to, anybody else have any other comments or anything you got? And Jim, how are you doing? Jim Augustine, how are you doing time-wise? Are you okay?
Hi, Paul. I'm good on time. Thank you.
Okay, I want to make sure we get a report in for you, but I wanted to get on to some of the other topics we were going to do today. Thanks a lot, Ben. That was a good report. Hey, Joel, can you get us up to date on, I think it was the yield to peds, right? That I put in there. That's a cool. very cool title. I like it.
Someone created it. I went with it. So I just want to touch on a few things pediatrics. And it helps if I'm actually able to look at my PowerPoint slides.
We're seeing it anyways. Yeah, there you go.
Yeah, but unfortunately I can't see it myself. Okay.
Oh, that's interesting.
Okay, so quick introduction. I don't know if many of you know a lot about PCARN. Most people think about PCARN.
Let's assume that they don't. We'll say it's a network for studying pediatrics.
So,
right? Okay.
so most people, when I say PCARN, they go, "Oh, traumatic head injury. Should I scan a kid or not?" But PCARN is actually it's where we do it's kind of like the rock of the pediatric emergency world. But to explain it a little bit better about the giant pediatric national kind of force is going out. So Dr. Julia Magana out of UC Davis says it best. So if you imagine your hand, your palm is HRSA, and HRSA funds everything. And then out of Mothership HRSA, you have 5 different branches. You have your EMSC state partnerships. So every single state has a state EMSC chapter that helps push down information. You have your EMSC Education Innovation Centers called your EIIC, and that's where they take in everything and they channel it into free education for clinicians, nurses, pre-hospital providers. There's PCARN, which is the Pediatric Emergency Care Applied Research Network, where it is across the nation, 8 research nodes. Each node has 2 hospitals and 1 EMS. And of those, one of the, is a specifically EMS node. They do EMSC targeted issues grants, like really large funded studies. And then they have a data center where they take in all the research stuff, and they have a group that actually collates it. So if you want to do research using PCARN data, there's actually a method of doing it. So from PCARN, one of the research nodes is called CHAMP. It's the Charlotte, Houston, Milwaukee node, and we only do EMS research. That is what our entire focus is. At our last PCARN meeting, which was a week or 2 ago in Washington, D.C., they came out and let us know about the Pediatric Pandemic Network. So if you haven't heard about the Pediatric Pandemic Network, ASPR basically came out and went, we need to do a lot more for pediatric disaster. We don't have a lot of children's hospitals. We don't have a lot of beds for kids. We need to kind of have a better way to look at this. So they split the US into 3 different areas. There's RAPM, there's the Global Pandemic Network, there's something up in the Northeast. Well, they did a lot of great work, and then they merged together and they created the Pediatric Pandemic Network. And they are starting to work with PCARN. That started at this last meeting. And the big thing about that is PCARN has one method of funding. Pediatric Pandemic Network has another method of funding, and they are all basically looking at sick and injured kids. So if you guys are looking for funding for large projects and they involve pediatrics, these are 2 great places to go to. In terms of the EMS group from PCARN, it's called CHAMP. We are doing research on asthma, both high acuity critically ill asthmatics, along with low acuity, who are kind of kids that maybe you don't have to transport into the hospital. Can we give them Decadron and not transport? What is the optimal dose of benzos for pediatric patients? They are starting to do enrollments this, I think, in May for the PD part, which is a randomized controlled trial of pediatric BVM versus supraglottic versus intubation, and pain management. Basically, what they've shown with the pain management through this node is we suck at looking at do kids have pain and then adequately treating it, and realizing you can treat pain in kids with needle-free techniques. You can do intranasal fentanyl, for example. So these are just some highlights of what has come out with CHAMP and what's kind of being worked on right now. We are on social media. So if you want to know kind of what's going on, feel free to follow us on this, and we'll try to push things out. Switching over, so we did PCARN, CHAMP. Now for the EMS Innovation and Improvement Center, the EIIC, which is much easier to say. If you want, free education is coming. Now, if you work in an ER, you probably have heard about the Pediatric Readiness Project. If you haven't, dear goodness sakes, please look at it. Because what they found over the past decade is if every single emergency department is prepared for kids, if you are a high performing emergency department, your odds, the kids who are critically ill and injured have much lower morbidity and mortality when you have a prepared ER. So what they're doing now is they're bringing this to the pre-hospital space. So in May, they're going out and they're going to survey all EMS agencies. So be prepared for this survey to come out to you. Know who's the person who should actually answer this. And they're doing a gap analysis for how are EMS agencies doing with pediatrics. This is going to be followed with actually tools on how you can close the gap and improve your agency for pediatrics. All of this stuff you can find on the EIIC's website. I have a picture up here to show you kind of like some more information they have for that. Also on the website, you can find free education. This is absolutely fantastic. So they call them peaks. Right now we have peaks for status epilepticus, suicide, pain, agitation, and child abuse. And I should say very clearly, I don't make these. These are pediatric EMS experts from around the country are actually coming together to create this for you guys. This is an example of how they look. This is status epilepticus. And if you go in, you're like, well, what do we have for pre-hospital practitioners versus clinicians or nurses? There's 9 different things you can get from here. You can get free sims, you can get recommendations, you can get video training, and it's all there and ready for you guys to use automatically. So again, those are called peaks. And when we have new peaks come out, I'll go ahead and let you guys know. And then lastly, we created the Pediatric EMS podcast, and about quarterly, me and Joe Finney go and we put out a podcast where we interview experts and we talk about kind of hard-hitting peds EMS things. We had one on cardiac arrest, one on disaster management, actually about the pediatric shooting in Uvalde. Talk about seizures, drowning management, prevention of drowning within your community, and the upcoming pre-hospital pediatric readiness. So that was it. There's a whole lot on the pediatric front nationally. I wanted to kind of get you guys in the loop for. Thanks for your time.
That's great, and really good review. And I think what you did was really good to make sure they're aware. I like the palm thing. It reminds me of some hand stuffing, hand ready or something, the approach to things. I can't remember what it's about, but
it made it so much easier to understand when she explained it like that. And I was like, oh, I did not realize how everything actually related.
Well, thanks for palming it off on Peter and Debbie here. Go ahead, Peter.
Oh boy, that was good. Okay, maybe not so good. Joel, great explanation. My question to you is, this pre-hospital evaluation is going to be a survey. And I wonder if into the future, we will be using, measures, for example, NEM score measures, actual real measures from real patients to see how that EMS system is doing, because I think we would all agree that whoever fills out the survey is basically going to just say, oh, how are you doing? Oh, I'm doing pretty good. But then when we look at the actual data, and for example, the folks in Florida, Tom DiBernardo, Shepke, Steve McCoy, they've done a great job of giving us dashboards through Biospatial. And now we have FAIR measures. I can look at my Coverdale measures. I can look at all these measures of my individual agencies and say, hey, we have these asthmatics, they're not getting albuterol. These hypoglycemics not getting dextrose. Seizure patients not getting benzos. People who are being intubated who are becoming hypoxic. Is there a way of actually measuring quality using actual data?
I think there is. We're just not there yet. I think there are EMS systems that are very advanced in terms of their data use and their HIE and getting their data to their state and to be able to compare for metrics. There's agencies that are internally might do really good data analytics, but they're not getting it externally to externally compare. I think this is a way classically and they haven't released what they're actually looking at on the survey yet, but for the emergency departments, what they've classically looked at is, do you have pediatric equipment? And they check it off for all different sizes. Usually they were missing the neonatal stuff like neonatal and tidal CO2 capabilities. Do you have a QI program for pediatrics? Do you have training and education? Do you have a person who's actually designated to look at your pediatrics? And then they score it. And then you can go ahead and compare yourself to your state, to the nation. And then you rescore yourself I think it's like every year to every 3 years to see how you're doing. And it's really moved the needle in pediatric readiness in emergency departments. And we're looking to do that for pre-hospital. Make it like really just concrete. Do you have XYZ? Do you have this, and kind of make it easier. And then hopefully, if you're doing that at the same time you're putting your data forward, you'll watch the needle move on those QA metrics that you're actually following from NEMSQA.
Right. No, I appreciate that. I just wonder whether being prepared and actually getting the work done and actually kind of showing, if there was a way of even taking 10 or 20 agencies and looking at the ready, maybe this is a future project where you take agencies who are quote unquote pediatric ready, and then you were able to compare their outcomes. Just curious as to the next step. I love what you guys are doing. You guys have definitely moved the needle at the national level. So thank you so much for everything.
Oh, I can't take credit for any of this. I'm just sharing other people's really cool work.
Yeah, you can.
Maybe like 1%. I think you're up there. Okay. Joelle, hey Joelle, by Meg Marine, I'm going to warn you. I'm going to get a comment from you in a second. Joelle, on the thing about Stats Epicus for kids, I'm really acutely interested in that topic, and we're going to bring it up at our Fort Lauderdale meetings. So can you do a presentation or go review the data on that and give us a quickie presentation on it as part of your thing in in June?
Oh yeah, that'd be easy to do.
Yeah, and there's just to jump ahead. One of the reasons why is that we recently had a paper I've submitted, for publication that we've sort of talked to you all about before, using ketamine as a rescue drug when all those other things like midazolam don't work. And so one of the interesting things that came out of that, and I called it barroom peer review, because some of the neurocritical care guys were saying that there are some drugs that you could stop the convulsions on, but they still may be seizing, in there, and you just don't see it. You don't know. You have to look at the EEG. So I don't know if that's the case with certain drugs that we use as rescue drugs versus ketamine, or if it's just a generic thing, but it's something we all need to be aware of. It doesn't mean that you still don't try to treat the convulsions, right? But it's just an interesting topic for me. Okay.
I really like to simplify it down and just be like, are we even teaching what seizures look like? Are we teaching what atypical seizures look like? Or even to open the freaking eyes and see there's like eye gaze deviation just because they're not moving their hands and legs?
Yeah.
Are you checking for hypoventilation when they're O2 stats? I mean, there's all these really exciting, sexy talks about all these new medications. And then there's just the basic things that we're missing.
Yeah, I think that's fantastic. So okay, you got a job set up for you. That sounds good. But no, but I think that's exactly right. So that's fantastic. So thank you so much. That neat presentation. So Meg, I don't know how many people know, but I hope they know that you have the pediatric background as well. In fact, you're so pediatric oriented, you even wrote a children's book, if I remember correctly, right? If you want to tell us.
Yes, I did. Thanks, Paul. I wrote a book about bringing people together about 5 years ago. And so,
oh my God, I can't believe that came out of Meg Marino's mouth. No, it's fantastic children's book, so it's great. Thank you, Meg. All right, but go ahead. Any reaction to what we've just heard just now?
So it's phenomenal, the work that's coming out of CHAMP and PCARN and the EEIC has really transformed pediatric pre-hospital and hospital care over the last over the last 10 years. I've seen a huge change and shift in this space. And so the work really does make a difference. And I don't even know if it's really moving the needle, but I mean, I think we're seeing like leaps and bounds through all of these individual projects. And so it's been really exciting to see that shift.
Okay, fantastic then. All right. Anybody else have any other comments before we move on to some other topics? We're going to be hearing from Don Jenkins. We're going to be hearing from John Jew, etc. Anybody else have anything else to comment about this particular area that we're addressing right now?
Paul, please don't be jealous, but my kids have a signed copy of Dr. Meg Marino's book, and they love it. So thank you, Meg.
I am jealous.
I'm showing off right now.
Hey, Joelle, why don't you make your external copy? Let's see if we can get her head to swell more and get the mannitol out. But go ahead.
I have an amazing copy. We read it all the time. We love our book.
Well, good. Hey, I'm serious. It's okay to self-promote here, Meg, amongst us friends. And so if you don't mind,
And Mark actually put the book in the link. So if you want to go to the link, it's
oh,
right
that's
there.
what I was gonna say. Yeah, there it is. Okay, yeah, that's fantastic. Tell us how you came up with the name, by the way, for the main character.
So Chepecho is an animal that has two legs like a bird, two legs like a horse, two wings like a bird, and a fishtail. And so I used the Spanish, French, and Italian words for horse, fish, and bird to come up with Chepecho.
Fantastic. Yeah.
And because she's a little bit like all of the animals, she can teach the animals that they don't have to be afraid of each other and that they can all play together on the beach.
Okay. And so, Mark, how did you know about that? Thank you for popping that in there. What's your background with that? Go ahead.
I didn't know anything about it, but just figured if there's a book out there, I was going to look it up, and here we go. So it's not self-promotion if we're promoting it for her.
That's right.
Exactly.
I hope, yeah, that's it. So it's good. Yeah. So, but well deserved too. So this is great. Well, thank you so much. Yeah. If you drill down, some of our people are very, very talented in many ways. So that was great. Well, thanks, Meg. All right. Anybody else have any comments from not only from the land of children, but the land of PCARN and this thing? Okay. If not, let's move on to some of our other topics. Donna, I'll probably have you on pretty quickly. But before we move on to that, let's get a brief ID report, infectious disease report from our in-house, infectious disease expert and board certified, ID guy, Dr. John Jew out there in Portland. Okay, John, anything you could tell us about? One is that anything we need to know about adults versus children getting measles, right? And two, why is this happening? And then finally, do you expect things to get worse? And then the real finally is, what should we tell our EMS folks that we're responsible for?
Yeah, Paul, can you hear me okay? I assume you can. Measles continues to be a major problem, especially for our pediatric colleagues as well as for our older adults in immunocompromised areas. What's really happening, I'm not sure it's worldwide. I'm interested to see what Nick Malloy thinks about it. But I think our immunization rates have gone down really markedly in the last 5 to 10 years. So measles, the top talking points are the following. Measles is one of the most contagious diseases we know. It's R naught value. In other words, one person can transmit up to 10 to 18 or even more individuals. Number two, it is airborne primarily. So if you stand in a room, even with a mask, your chances of getting measles, if you're not protected, is very high. Number three is that our crowded areas, especially with one person, especially like an airport or a school, could really basically infect the entire school or the area surrounding the airport. You can be in an ER, not in the same room, and basically get measles here as well. The virus is actually a paramyxovirus, and it's airborne. It's usually in the upper respiratory epithelial, and it's
Let me interrupt you for example. Hey, John, let me interrupt you. You said, what kind of virus is it?
It's a paramyxovirus. It's an RNA virus.
Okay, got it. Good. Okay, go ahead.
Yeah.
Yep.
And so I think there are 2 or 3 different phases. Number one of them is the pre-rash phase, and that's manifested by what we call the 3 C's: coryza, conjunctivitis, and I can't remember what the third C is. Basically, viral URI, followed by conjunctivitis and a high fever. Does that make sense? That's about 3 to 4 days before. Then the onset of a rash. So the mistake that clinicians and providers have is that they're looking for the rash when the person might have a high fever. Does that make sense as well?
Yeah, right. And it's interesting because there's some diseases in kids particularly where they may have a rash first, then they get but in measles it's a flip side, right? So
yeah, they are infectious 4 days before the rash occurs and about 4 days afterwards. That's number one. So they are infectious during that period of time.
Is there a typical aspect to the rash, by the way, in terms of palms and soles and trunk and base? Yeah.
The rash is ubiquitous, and it's been about 10 or 15 years since I've seen a case of measles myself. I used to see it when I was much younger in my career. But there's a classical Koplik spot, and there's a whitish spot in your mouth. They look like basically Candida if you're not really used to looking with it. A high fever with a Koplik spot in a young or an adolescent is really a problem. Kids and older adults die of about three or four different things. One of them is encephalitis. The second one is pneumonia. The third one is actually diarrhea in a developing country. The protection is usually, there's no antivirals effectively. The protection is from prior immunization with the dosage. I won't go into the details of the dosage, but it's the 3 MMR dosage. It's a live virus, by the way, so you have to be a little bit careful. There is a post. If you have a individual that has been exposed, there is a combination of 4 days afterwards. I think you can give MMR within that 4 days, and you still get protection. And for especially certain individuals, like immunocompromised individuals or pregnant individuals, you can get IgG up to 6 days as well. I think that's about it. So the question is,
anything we need to know about?
The answer is,
yeah. Before you go any
ahead,
further,
Paul.
in terms of how it manifests in adults, I guess people who are visiting from another country that never got vaccinated or immunocompromised people, what do you typically see?
You will actually see the classical thing. In other words, the presentation is, and we're going to miss it in the ER. I can tell you with a really high fever, if I see Koplik spots in a person that we know the exposure, then it's pretty easy. But the run-of-the-mill Joe Blow with high fever, I'll say, I have no idea what's going on. If they have the rash and they had the exposure, you have nailed the diagnosis. But by that time, you infected the entire ER. Does that make
Right?
And all the healthcare providers that are sitting there.
That's sort of my point. So yeah. We got to be on the alert for it, etc. Okay. And then Dr. Koplik would be really proud for reminding us about him, right? So,
yeah. But I think for me, the really high fever and the conjunctivitis and a person who's not immunized should bring that issue up. Does that make sense?
Say that again,
so
John, I'm sorry.
That is probably the really high presence of high fever, cough, and conjunctivitis is the prodrome before you get the rash. Once you get the rash, then you end up basically taking pictures of the rash, send it to a dermatologist and say, this is measles, or this is measles, if you know how to recognize it.
Yeah, so that's one of the reasons why I brought it up, because it really is a little bit of a there. I'm going to have 3 people comment. First Peter, then Jim, and then go on to Joelle, because she's been seeing a lot of it, unfortunately. Peter, go ahead. Your first comment.
Yeah, so I'll put up on the screen. We just got this literally about an hour and a half ago, that apparently now in Broward County there's a case. So it's happening right on time, John. Thank you so much. Paul, back to you.
Yeah, and John, hey, oh, by the way, John, I think the third C is cough, by the way. Just
okay.
Conjunctivitis, coryza, and cough. Okay, got it. Hey, you seen anything like that out in your neck of the woods, Jim, Augustine?
Yes, in Dayton, Ohio, one child who did travel, 350 contacts being traced for 3 weeks. And so it really is a load on public health. John, I wanted to ask you about the changing guidance on isolation for COVID and the reduction in the 5-day. That's going to have a big impact on public safety forces.
Yeah, it is, Jim. But honestly, I think it's a combination of public pressure as well as, in other words, COVID really hasn't changed. But what's changed was everybody's been exposed, and everybody's had immunity. By the way, I'm not throwing Nick Malloy underneath the truck right now, but our COVID cases our measles cases came from Europe. Does that make sense? So Europe has got a problem with measles here as well.
You didn't throw them under the truck, you throw them under the lorry. I just want you to know.
The lorry. Okay.
Let me jump ahead to Nick. Nick, do you want to say something about that and what your opinion is, or any comments for us,
Yeah, so I mean, measles vaccination had been a good rate in Ireland, and then we had that very tenuous association with autism, which has been completely debunked, but that sent the measles vaccination program through the floor. And in the last couple of years, we've had a couple of outbreaks. And this particular year, there's been a lot. And one man, unfortunately, has died so far, a mid-30-year-old. We have another child who looks like they might unfortunately pass away, but a lot of kids in intensive care at the moment in multiple different units from this. So we got, similar to Peter, we had a suite of documentation sent out to us all today about where we can get vaccinations for staff, how to recognize, because we wouldn't see it very often, and about wearing FFP2s ourselves in work if coming across cases of fever. So it's challenging at the moment, and we have quite a number of people, obviously in the last year or two, who've come to Ireland from Ukraine or other countries in Europe, which wouldn't have had vaccination or good vaccination programs up to now. So we're trying to do a catch-up vaccination across that group.
Yeah. So John, let me ask you this. This is an interesting theoretical question. So many of us, for example, myself, had measles as kids, right? And then a lot of everybody else has gotten MMRs in our country pretty well. Is there any reason to do reboosting just for extra protection, particularly if you're older?
I can't, for normal, with individuals with normal immunity, the answer is probably no. You really don't need to have that. But there was a 1957 law that basically is if you were born before 1950, this is in the US, I don't know what it's like in Europe, but if you were born before 1957, you don't need to basically get vaccinated because you're presumed to have measles here as well. I just need to point out the following, that we have a huge surge like everybody else in the world of our immigrant population, no matter where they're coming. That is our vulnerable population, and the vast majority of them have not been vaccinated against measles adequately. So that is basically where our outbreaks are going to occur. In addition to, Oregon has a quote unquote a whole high non-vaccination population. So there's a whole bunch of people that don't believe in vaccines sitting in Southern Oregon as well.
Yeah, and I think that's the problem. And you take a place like Ireland that's been. I'm going to go to Mick and then over to Dave Obert in a second, and then Joel. But you take place Ireland, which was really, I mean, the whole country was so compliant on the COVID end. It was like impressive to still have some kind of vaccine resistance there. Boy, it's going to be worse in our country. So that's the problem. When I was talking about the reboosting, Mick, what did you have a reaction to that? What I was saying?
No, yes and no. So we are actually being advised the older groups of staff to get boosted for measles. And they said that anybody born before 1978, sorry, the more recent higher staff, anyone born before 78 probably had measles as a child. If you're born post 78, we need to check your vaccination records. Now, the vast bulk of health staff, when they come into our system, have titers taken for measles, mumps, rubella, chickenpox, and a range of 3 or 4 others. So most will be covered, but some people come in as contractors into the system and don't go through that. So we have to go back to that group now, and they're going to be offered vaccinations.
Okay.
And they're trying to encourage surveillance as well. So they want us to swab and send the stuff off so they can get a better handle of what's circulating.
All right, let's get an opinion from North America. David Obert, go ahead.
Thanks, Paul. I was just going to ask John in terms of the possibility.
Tell everybody where you're from, okay? So, and what you're
Vancouver, British Columbia, in Canada. Have not certainly not this go around seen measles cases, although in previous there have been concerns about it in the past. My question for John was about sort of atypical presentations of measles and perhaps the possibility of, I guess, waning immunity. And it was to, I guess, jump on what Mick had just mentioned about, I guess there's 2 ways to do it, sort of a reboostering campaign versus, I suppose, checking people's titers, which would be probably a logistically very heavy lift. But I was just curious to know about the possibility for atypical presentations in people with perhaps lessened immunity. And then number 2 is, are those people as infectious with such a high R0? If they're having any manifestations of measles, is that just as risky for spreading as somebody who, let's say, was unimmunized?
Yeah, David, that's a great question. So the quick answer is that atypical presentations, low-grade fever, coryza, conjunctivitis does occur, and it's usually been reported in young teenagers and young adults who have waning immunity. So I think in a presence of an outbreak, most public health individuals, including myself, would recommend boosting that population with one or two, probably a dose of 2 MMRs, I think, and the usual precautions here as well. What was the other one? Other question, David? So atypical, boosting, and what was the third question?
Oh, it was just in terms of the infectiousness that you had mentioned. That really,
yeah, the atypical, I have to check my basic science. They are less infectious because they have some immunity, but they are not as so high that it probably doesn't make any difference for people that are susceptible. If you have no immunity at all, you're going to get measles, period. The other problem that occurs is that we're in a developed world. If you're in a underdeveloped world, albeit the case fatality rate could be as high as 10 to 15%. This is a lethal virus in that setting. So it's very lethal, like diarrhea.
Yeah, absolutely. So that's just another reason to bring it up, because I think there's higher risk than ever before. Oh, John, is there any risk to someone? Let's say they did have measles, let's say whatever the born before or whatever year it was, they did have it. Is there a risk if you boost them of some bad reaction?
Yeah, in other words, there's probably not a risk, but it's a live attenuated virus as well. And so if you're living in if you're working in a quote unquote setting where you have immunocompromised patients, that is a problem. You have to be careful. There's an MMR.
Yeah. Okay. Yeah. Fantastic. Okay, good. Let's go over. Joelle, you're seeing bunches down where you are, right?
Well, we've had we've had at least one, and then we've had a contract trace it out. We had it on February 1st, which was, I was lucky to be an ER doctor on shift that day. But over the course of through the last decade in California, we've had numerous outbreaks. We had our Disneyland outbreak in Orange County, where I had some patients. Up in Fresno, we had a few patients. In San Diego, we had the Disneyland measles outbreak spread all the way down to San Diego. And I'll share my really memorable measles case in Fresno. And I remember I walked into this room, and it's one of the, those big shared rooms where you have like 6 kids sitting there. There's just the curtain is going between them. And I looked at the kid, and they're just wet because this cough coryza conjunctivitis. This kid looks at me, just watery eyes, super sniffly, wet cough. And then there's just a rash, like this just generalized rash over his head. And I looked at him, I went, "Hey mom, does your kid still have a fever?" And mom's like, "Yeah, I still have a fever." And I just turned around to the nurse, went, "Put on your mask and empty out the room. We've got to shut this down." No one believed me that it was measles. Sure enough, it was measles. We had it was this nightmare. Like every single time, one single case of measles, you have to shut down that entire area for at least 2 hours, and then you have to contact trace everyone that was in there. So our most recent one in San Diego, we had the measles case February 1st. It took a good week to actually get everyone notified that went through the emergency room. And then we had to have all of our ER staff be prepared that people are coming back through the ER to get, like, if they're this age, they're going to get their vaccination. If they're this age, they're going to get immunoglobulin, and coordinating between pharmacy, the ER, and all the families, everyone that's coming through.
Yeah. One of the things that I think I'm taking away from this is that number one is that anytime you're seeing someone that might be sick with anything, I always like to know, have you traveled recently anywhere, or are you from somewhere else? And that also, both of those are different questions. One is just, have you been exposed or been somewhere like out of the country, or traveled recently is a more generic term. Then the second was, are you from some area? And it really is profound sometimes, the things I've been able to pick up on when you say, "Oh, where's your accent from?" And they start talking about the north part of certain countries, let me put it that way, where you might have river blindness, that to account for the loss of sight. So I think that's just an important thing to ask just really early on about travel, especially in this world today. And then, or if they came from another place. Secondly, is that I think a takeaway for me here is that the profound high fever shows up before some of the other things, and that just to be on the lookout for this today as part of our package is what I did. John, anything you'd add to that? Okay.
No, I think you got it really well. We just had a case in Vancouver. It's sort of interesting that Florida's reporting this. So we had a case in Vancouver in the last 2 weeks. Vancouver Washington, not Canada. Sorry,
Right.
sorry, David. But it's interesting that we're reporting and Florida's reporting it. So there must be something going on. The patient came from Europe, by the way.
Yeah, yeah, and then it's the southern peninsula there, just like the southern part of the Washington State there, right? That's what it is. No, but yeah, it is interesting that it is and yeah, the distant corners that they do exist, right? It's happening. That's why I brought it up today. So thank you, John, for putting you on the spot just like that. All right. All righty, let's move on to a couple other topic. Anybody else have any questions or input or anything else they want to ask? If not, then let's move on to John Jenkins. We had issues with the DEA. How about the FDA? But before I go there, Sandy Schneider, anything that's has this been helpful to you or something that'll be are you guys on top of this or thinking about getting on top of it? The
Yeah,
measles.
we have a listserv that's called Emerging Threats.
Yes.
And for I kind of just pull stuff from the CDC and anyone else, and Joe, of course, anything that John says. And I put it in here, and that will definitely. It's been in the last couple of issues, but I've got some more data from you guys. So thanks.
Anything to add then to what we've said so far?
No.
Okay, good. All right. Thank you.
This is always so very helpful for me and for everyone.
Good. All right, so let's move from the DEA to the FDA. I just want you to know, John Jenkins, years ago when I was getting AEDs out there in the public arena, like when we did that study I did at the Chicago airport, there was confrontation from the FDA, and we actually wrote an article that was called FDA confrontation without comprehension. And I think I was audited by the IRS for the next 3 years. No, but tell us what's the latest twist with the FDA.
Ouch, yeah. Can I share a screen?
You can. I guess I don't know if I have to allow you to do it, but everybody else has been doing it.
I'm just gonna try to hit the button here. I did share in the text the link to what I'm about to show you.
Yeah, and I'm ignoring all text while I'm on this, so you might want to send it. We may give you a better place to send it to, so someone like Dr.
Are you seeing my screen right now?
We see you zooming away on that screen. Yep, we got you.
Okay, you see that? Okay. All right.
So this the code of Federal Regulations Title 21. We got it. Okay.
That's correct. So this is the link I just sent you. And if you scroll down way down here, sort of in the fine.
Hey, Don, did you put it in the chat? Because sending it to me is going to be useful. Okay,
I
good.
did. It's in the chat. So way down here, kind of as an afterthought, Roman numeral 5 under this 606.160 is a single statement that says emergency release of blood, including signature of requesting physician obtained before or after release. And this comes under this records section of what is necessary to be performed and retained. And so I don't know how many of you are familiar with this requirement. Certainly inside the hospital, everything that gets ordered, distributed, every transfusion, it requires a signature from somebody. But what this is saying, and this was espoused by the folks who wrote this regulation at a meeting I attended for 2 days this week, is that this applies to the pre-hospital arena. So any blood product being administered when you don't have that a cross and type match, right? I'm sorry, a cross and type on that patient, right? So you're issuing this as emergency release product. This signature is required. I don't fully understand what the FDA considers their realm of jurisdiction. But clearly they felt that it includes what happens on the streets of or in the air across this country, that this needs to be done. There's a jillion ways of doing it. I'm just saying that this is a current and an existing requirement that we learned about. Now, we learned about this at a meeting of the, it used to be called the American Association of Blood Bankers. I don't know what their new name is, but they kept the abbreviation AABB in that name. The AABB is writing standards for out of hospital and pre-hospital transfusion. And by out of hospital, they are referring to infusion centers, home healthcare agencies, et cetera, something that is not 911 EMS related, but doesn't happen inside the confines of a hospital. And the guidance there, there are about 10 sections in a 45-page document. 9 of those apply to, 8 of those apply to both out of hospital and pre-hospital. 1 section specific to out of hospital, 1 section specific to EMS. That document is the representation, if you will, at the AABB table was me, Eric Bank. I don't know if you guys know Bill Bullock from San Antonio Fire, Randy Schaefer from this group, among others that were online that I don't necessarily know their roles, but they tried to be as inclusive as possible of these out of hospital and pre-hospital folks, along with their own AABB, FDA. There were a number of blood suppliers in the room and online. And that draft will be coming out in about 60 days for public comment. The expectation is that the public comment period will be during May and June, coincident to both the Eagles meeting and the National Whole Blood Summit. They are going to come to the Whole Blood Summit. They will have a 15-minute sort of presentation to make. They will have educational materials and a table there to further discuss and take public comment as a part of that. They're very interested in interfacing with the Eagles at my request and with the attendees of the National Whole Blood Summit. So if there is bigger interest in this group to participate, there will be a public comment period possible for that.
Okay, let me jump over to John Kramer because of his leadership role in this arena. And John, what's your reaction to this, and what can you tell us about that?
Well, I think at least with the folks that I've talked with who attended that AABB meeting, first of all, it was a good meeting, as Don alluded to. I think this was a little bit of a surprise. I think that it is not an insurmountable issue. It just requires folks who have blood programs to establish a mechanism that they get an appropriate signature from the medical director of the agency. It can be done electronically. It doesn't have to be done in hard copy or face-to-face. It's something that I think the agencies are going to look at and figure out a way to address. I don't know if Eric is still on the call, if either Eric Bank or Don have a comment. There is also a requirement that the agency have available at the time they're administering a blood product. They have to have the AABB circular available. I'll defer back to either Don or Eric Bank about the implications of that.
Before we go on to Eric, let me ask you this. So you're saying, let's say there's a medical director's signature for standing orders for something, right? So if we say the standing order is for blood, or does this have to be done every time in real time? Is that your interpretation?
It's my understanding that it has to be done every time in quasi real time. There's some leeway in how quickly the physician needs to sign the order. No, that's not true, Don.
So there is no time requirement listed here. There is a sort of an expectation that it be done in relative real time, but there is absolutely no requirement written out here. That's why I sent the link so you can look this over, because it is open to some interpretation. But all it says is emergency release of blood, including signature of requesting physician, obtained before or after release. And after a wide open word.
And a protocol signed by your medical director does not suffice. It has to be related to the specific administration for a specific patient.
That is absolutely correct. And that the availability of the circular of information from the AABB is you just have to have access to it. It's available online in a PDF. You are eligible if your blood supplier is required to give you a copy, and figure out what copy means. Could be an e-copy, could be a hard copy. That blood supplier is required to give you a copy at your request. So both, I think Eric and I both picked up a copy at the meeting here in San Antonio.
And Peter, I believe that it can be an electronic signature. It doesn't need to be a physical signature.
That's correct.
Eric?
Yeah,
That's actually a very important part of it,
and you can batch them, right? So you can do them in 30-day intervals. You don't have to do it, right? So here, and Dr. Jenkins and I were next to each other. Randy was in there, Bill Bullock from Dr. Maramonte's shop, and then if you guys know Dr. Jeffrey Siegler from WashU was in this as well. So these are things doing this for a while that I have never heard of, right? So the signature thing, the circular deal. So basically all I did, and most folks are in some sort of electronic protocol format, is you can get this as a PDF and just have it available. So, in a semi-jokingly manner, as Dr. Jenkins and I are sitting next to each other, we're like, hey, excuse me, sir, I know you're shot in the chest. Would you like to see the blood circular before we transfuse you? The other interesting point that actually came out of this, and this is for something for you guys to go back and check, because I had to check, is so technically the blood is supposed to be typed twice. And so a lot of times when what's referred to as the blood bank sends out blood, and Dr. Maramontes, you have no worries there. You guys have the best blood bank in the country. It has to be typed twice. So your blood bank may not be typing your blood when it goes out to you and expecting that you, as the lab, which of course none of us have, are typing the blood a second time. So just another question to go back and ask your blood distributor. Are they performing the second ABO type before that blood comes to you?
And so the big blood distributors, right? So if let's say you get your blood from a blood bank, the blood distributor has a requirement to test that blood before it goes out. If the blood bank gives it to you, they are not necessarily held accountable for doing that. That falls on the recipient to make sure it's typed twice. And so it may require a mother may I of who you're getting your blood from if it's not already run through the double typing, and it's for safety reasons. There's another requirement that you have a mechanism for performance improvement, that issues are discussed, issues come forward, issues are discussed, et cetera, et cetera. Those of you that I'm sure you have a mechanism for that. For any of those kinds of issues that arise in that setting, you just need to make this a sort of a standing agenda item.
Okay.
Yeah. Don's comment reinforces the fact that EMS agencies have to maintain the integrity of the blood component container even after it has been administered, and deliver it to the receiving hospital.
Exactly right. So far, we've had no problems overall with giving the blood in the field, we like to say, but something comes up somewhere, we've got to make sure we have the trace. And I think that's a really important point to bring up, John. So thank you so much for that.
Yeah, these are administrative and regulatory hiccups that the agency needs to address, but it doesn't significantly impede the development or implementation of programs.
So
Yeah,
it looks like
nothing's
it look-
insurmountable with these.
Yeah.
Sorry.
So it looks like Meg popped off. I was going to ask her, but I assume this is not just the whole blood. It also it goes
Any
through
blood component,
RBCs, any good blood. Yeah. Right.
any emergency release that you are giving blood to a person that you don't know its compatibility with that patient.
Okay.
It requires that signature in the hospital, out of the hospital,
Wherever.
EMS, doesn't matter.
Okay.
Don,
and
Don,
the
how
known-
about these? I'm sorry, Paul.
No, just saying it's an inside joke between me and Don about within the known universe. Okay, Don.
Yeah, that's the jurisdiction of the FDA. Yeah.
Yeah, right. Go ahead, Peter.
Yeah, just along the same lines, and maybe Don or John can answer this, but I was very impressed with the that freeze-dried plasma product. You know, it's very lightweight. You just add saline type of thing. Is that also going to be involved in this signature, because it is actually someone's plasma?
Yeah. So the rules of engagement will come down to I think where you get it, right? So if a organization you're procuring that from considers themselves to be a distributor of like an antibiotic, like coming out of a pharmacy, the rules of engagement would be far different than if it comes out of a blood bank. We internally here are pushing every product like that we can into the pharmacy arena because it is far less onerous to work with them than it is with the blood bank.
Oh yeah.
Yeah. So I think those products coming out in the future, this is an opportunity for us to influence how they come out.
Cool.
Right, yeah, I think John's product is being made. Isn't the Velico product being made at the blood bank? If I'm not mistaken.
That's correct. I mean, the ODP is just a process for preparing the dried plasma. It is still considered a blood component and is being it's actually being processed in a blood center.
Right. Hey, so it's time for me to wrap it up. I want to do a couple of things, maybe as previews. Glenn Asada and Peter and so on. I think when Chris Colwell and a couple of others can get on, we may talk about the shootings, because you guys have had some significant ones in the last week or so, or even the one that happened in the church in Houston. And Dave Burst can get on next week, so maybe we'll push it to next week. But the other thing is Rob Glatter's on, and then Rob, tell us what you're kind of interested in discussing with some of our folks. Ooh, is Rob, you still there? I'm sorry, I caught you off guard, probably, right? Well, Dr. Glatter, are you there? Probably he may have stepped off there, but it looked like he was. But anyways, Peter, tell us a little bit about what Rob wanted to talk to us about.
Well, I'm not 100% read up on the article, but there was a paper that was released. And again, I don't have it in front of me here, but essentially looking at how you can go to a different place. You can go across the street, and then that EMS system will have better or worse outcomes than the agency you just left. And the question is, why are certain systems higher performing than other systems?
Yeah,
I think that was the crux of the matter there.
Yeah, it's so the answers are easy, but it's like nothing new there in some respects. But why is it not? Why is it not something new, right? So, all right, well, good. Well, we'll see. We'll get a more further comment on that later on. Let's quickly round the room and all that. Glenn, anything out of New York that we should know about in specific, or we can put off till next week? Glenn, are you there? Seems like you're there. Okay, I'm not doing too well on this end. So, okay, David, anything out of San Antonio of note, or something we could put off till next week?
No, I just was going to bring up that we are in an effort to de-emphasize CPR and traumatic circulatory events. We talked about that last week. And we're also revisiting our trauma triage rules based on the 2021 revisions that came out. I'll send that article to Jim so he can send it to the group.
And just as an FYI to you, David, I'm leaning away from the mechanical CPR, but I may talk about something like you may want to do something, but maybe use something like the pump, what's that thing called, the rescue pump. There is some evidence people try to use it under those circumstances, and may have been some benefit. So just as an FYI, but
no, we're not eliminating it. We're just delaying it until you do stop the bleeding, push back or tourniquet, get a simple airway. open the chest. So if you put the Lucas on, you can't get to the chest.
Absolutely.
So that's why we want to have them do those things.
Yeah, absolutely. All right, that sounds good. Well, we'll talk about that more, but that's going to be another topic that we'll bring up at the main Eagles meeting in July then. Okay, so that's good. Let me see, anything out of Colorado Springs Stein that we should know about?
No, nothing really important. I missed the beginning of the meeting. We had a shooting at the university this morning, but it was an isolated, targeted shooting, thankfully. Nope, nothing important.
Good. I think I was going to ask Clayton next. If I guess he's gone already. That's too bad. He was really good. He was one of the people with doctor's appointments today, so he obviously came out well. That's good. All right. Let's see. Well, let me just put it out there generically, since it's already 10:03 here out the West Coast. Anybody else have anything to add in or want to pump in here for Dave?
I have a good outcome video. Can I show it?
Sure. Or I want to show it next week.
No, it's just literally 10-second video.
Okay,
But
sure.
I'm gonna pause the recording, and I've gotten permission to do that.